the organizing secretary for this webinar. So for today's webinar, there is a 3 sessions: inauguration session, scientific session, and open discussion. So for inauguration session, I invite Dr. Neeraj Agarwal. He is a professor and head as well as a medical superintendent in AIIMS Bibinagar. He is the backbone for this webinar and supporting pillar and motivation for all faculties or for our department. I invite Dr. Neeraj Agarwal for welcome please.
Thank you, Dr. Bhushan. I welcome our chief guest and director of the institute, Professor Vikas Wadia, Dr. Rahul Narayan, Dean AIIMS Bibinagar, lead of this whole concept of POFL, Dr. Pradeep Agrawal from AIIMS Rishikesh, Dr. Sudhir Bhattacharya from Mala Institutes, and the main pillar of conducting this program, Dr. Rashmi, and organizing secretary of this workshop, and Dr. Bhushan, and all delegates of this conference, and my faculty members of the department and the institute, and supporting the staff. At the outset of welcoming of this topic of childhood related obesity and other concepts, especially related to front packing of labeling of the things. I have a few questions I will put in our welcome address. First, I welcome you all. That's very spared the time for this webinar, and this is one of the many webinars which occur across all AIIMS and all states. And AIIMS Rishikesh is working as the hub of this concept, and other AIIMS and other medical institutes are working, as I spoke, and spreading the concept of and understanding of this concept of this problem. Other medical college of the institute.
Yes.
So, our director is just joined, Mr. Khazwadia. So now, with this background, I just put up 2 things. So there is a lot of discussion will go on this particular issue. But I put out 2 things which come into my mind. That when I used to buy something in market, then what happened that initially they give a manufacturing date. Now they have changed from manufacturing date to use by date, and that time sometimes they force us to buy things even up. So this is maybe made in a 5-day bag. I'm talking about the like bread and milk 5-day bag, but still they are putting a use by date. So they say the 1 day is left. My question is, why should I take a 5-day old things? So still 1 day left, maybe 1 day I can use or not use. Another issue which comes into mind, especially the children, that everybody in India, as per the advertisements come, that's every Olympic game and every chess game or every IAS officer is made when they drinks the Bonvita. So I don't know how much this issue is covered with this issue which we are discussing today. In my mind, that front labeling is a part, but also advertisement we can put some point so that those advertisement related to the nutritive things which are sold through various fast-moving consumer good, but through advertisement they make a lot of impression amongst the lay person, especially the women and the children who do not know many things about the nutrition, that these things are really good for their children and they can do excellence in those areas. So I hope that deliberation of this thing also lead to some highlight on issue, and maybe we can make some guideline for our government of India so that this advertisement can be modified so that some understanding of real nutrition value of these foods also came to know. With this background, I welcome you all again. I hope this deliberation will help us to make us some lead on this concept. Thank you.
Thank you, sir. Thank you for your welcome address and highlighting the issue of front of package labeling. Now, I request Honorable Director Sir and patron of this webinar, our beloved Director Dr. Vikas Bhatia Sir for inaugural address. Inaugurated by fruit cutting and inaugural address.
So, you want to buy it?
Yes, sir.
Inauguration.
First.
Inauguration.
थोड़ा इसको करो यहाँ तक आएगा.
So this is a very unique way and in fact goes well with the theme of this webinar. छोटे होते थे ना when we were the school time, somebody gives orange. They will do like this. It just reminds me. Burning good. That's that's fine. So this is good. This is the healthy food. Antidote of fast food. All right.
So inaugurate. Speaker.
Namaskar. Good afternoon. My dear colleagues and friends, in this place, we have Dr. Neeraj, our medical superintendent and head of the Department of Community and Family Medicine, and organizing team, Dr. Rashmi, Dr. Bhushan, faculty members. We also have our Dean, Academics, Dr. Rahul Naran. That's the team which we have in the from this place, from where we are organizing this webinar. I am pleased to sharing this platform with some of the eminent speakers who will be talking on various aspects. I am pleased to welcome them once again. Dr. Allappa, Dr. Sumati Swaminathan, Dr. Madhvi Bhargav, and Dr. Pradeep at AIIMS Rishikesh, and many more eminent speakers. And it is a great pleasure that today at this time on television, Prime Minister of India, Shri Narendra Modi ji, our Honorable Prime Minister, he is launching a very big nationwide program. And on our end, as a public health professional, we are also trying to support not only that program, we will be supporting wholeheartedly, but also working and talking on deliberating on one aspect which has been troubling us for quite some time. Change in the lifestyle. When we were students, we were always taught about the infectious diseases. And the most of the questions, the most of the textbooks will write chapters only on the infectious diseases, and less number of pages will be on the non-communicable diseases. As we saw the change in the lifestyle and the change and the westernization of our country, the culture which has reached to our country, has given us many good things in terms of technology and science, education and travel. But it has also given us certain things which are not healthy in nature. And one of them is the changing lifestyle and changing the food habits. About 20 years back, in 2000, I was in Chandigarh when I was working there. I was noticing this change which is taking place. I'll be speaking on this topic sometime later from now, today in the webinar. But this is how I found that, because as the per capita income of a place increases, people feel that eating those food items which are westernized or which we usually say they are unhealthy, they are a fashion. Now taking a lime water or an orange or an apple or any other fruit juice is not considered to be like a fashion, and the youngsters feel that instead of water and the lemon water or the coconut water or the buttermilk or any homemade food item or any drink, it is fashionable to have the Coke and all the manufactured which are commercial in nature. So these kind of changes which are taking place at that time, about a quarter of a century back in Chandigarh, I found that those things have really gone so far that not only is a modern city, but even in the rural and the remote areas, this has reached. You go to any part of the country, even I saw in the tribal areas of Odisha and also here also in Telangana, we find that very frequently I tell one thing, that you go to any part of the country and yet we say the number one killer disease is diarrhea. Under 5 mortalities, the diarrhea. It is yet, even today, it is difficult to find ORS package. You can say with confidence, are we able to provide ORS package in every village of this country? We are not sure. But we are for sure, you go to any village in this country, you will find that in that village, Coke and Pepsi and Uncle Chips and Kurkure and all those kind of stuffs are being sold. So what does it reflect? On one hand, we are not able to save thousands and thousands of children, under 5 children, because of the non-availability of the oral rehydration solution or a packet over there, which is life-saving. On the other hand, we are ensuring that those Cokes and the Uncle Chips and those potato chips and those kind of stuff, they are available in that village, which is harming and killing more and more children, more and more people. So apparently, these are two different part of the extremes, life-saving and life-killing. Today's seminar on front of the fact labeling and children's health is one of those areas which is trying to highlight this issue now. And this message is one step ahead, and how we deal with this, because ultimately what we are and how long we will live, it all depends on what we eat. People do not know what we eat. We keep on whatever is served, we keep on eating. Whether they are healthy, they are bad, or they are useful, we do not know. You ask even the very intelligent, educated people, how many calories are there in this? People do not know about it. You ask anyone how many calories are there in one samosa? People don't know. And people feel that I am on fasting and have only one samosa. And you ask somebody how much calories are there in one pizza. Even the intelligent toppers of the meat may not be able to answer this question. One pizza of the medium size is like 1,500 kilocalories, or a big size is more than the 2,000 kilocalories. The amount of the total calories requirement for in a day for an adult person. So what is this happening is we need to explain to everyone what is there, what we are eating. It should be clearly described. The Western world has become careful about what they eat. It is written on each and everything, on every label. Wherever I go abroad, whenever I see that in advanced country, they are very, very clear about it, what they are selling. But we in India do not know what we are being sold and what we are eating. And usually we end into many controversies at times. This food item has got this thing high or this has got. But ultimately what we see is we are bringing and new diseases which are non-communicable in nature, whether they are cancers. Where were the cancers 100 years back? But now you see it's so frequent and so many things which are emerging and so many diseases which are coming up. And this is all because of the change in the food habits. And I want to congratulate the AIIMS Rishikesh, Dr. Pradeep Agarwal, and the head of the Department of Community Medicine, Dr. Rashmi and Dr. Neeraj Agarwal team, who jointly are working along with taking this message forward to other AIIMS and other parts of the country. With these words, we hope together as public health professional, let's bring a change first in the children. Let's protect them from many, this kind of an issue which people are not able to understand. So creating awareness is very important. Thank you very much for inviting me and all the best.
Thank you, sir. Thank you very much for your right introduction and blessings to our webinar. So now I proceed. I invite Dr. Rashmi Kundabur. She is the additional professor and in the Department of Community Medicine and Family Medicine, AIIMS Bibinagar. And she is also principal investigator and co-chairman of this webinar. I invite Madam for concept note of this webinar.
The concept note of this webinar to start with, of course, objectives will be set by the lead project director, Dr. Pradeep Agarwal, who will talk about it. I want to overall tell what we are into is probably we have today 500 voices along with us who are going to talk about front of package labeling and children's health. This concept is on medical voices. Basically, we are looking into the medical voices like citizen voices coming up to say that though we have a law which has been already proven of front of pack labeling to enhance it. And whenever the citizen voices and the medical voices get together, we would be definitely going into having a large number of big advocacy all over the country. So this is a beginning which has been started from AIIMS Rishikesh and all through many of the already we have many places happened with the lot of webinars and medical voices have joined. This is one of such largest webinar where the medical voices are coming together and definitely we will work together forward with many other things where we'll also be talking about and saying that how front of package labeling is important as an health and what type of front of package labeling we would be wanting in future. And definitely would want also to say that in a future coming meetings which will happen in the south, AIIMS Bibinagar will be hosting one of the South regions meeting. We would be liking to work on what area of front of package labeling in the south we would want to work on and work together so that all over the country medical voices together for front of package labeling. Next, handing it over to the
Thank you, madam. Thank you for your concept note. Now I invite Dr. Pradeep Agarwal. He is Associate Professor in Department of Community Medicine and Family Medicine in Rishikesh, as well as he is a project leader of the Healthy Food for All. This is a joint webinar by the AIIMS Bibinagar and AIIMS Rishikesh. So I invite Dr. Pradeep Agarwal sir for objectives of the webinar.
A very good afternoon to everyone. Can we have the slide, please? Before we have the slide, sir, I'm very thankful to all three of you, sir. And under your unique leadership, that is a globally acclaimed leadership from East Australia to West America, from North Chandigarh to South of Hyderabad. You are among the best of the public health expert who have made it possible to deliver the content and everything out of FOPL. We salute your leadership, sir. From Chandigarh, you have given the example of how they have applied to the Hyderabad and even touching the tribal areas. We are really thankful to you, sir. And ensuring the best global evidence-based practices that should be adopted by India is the key goal by taking up such kind of awareness program. We are thankful to you. We are thankful to Neeraj, sir, for taking up the lead and for giving us all-hearted support and taking up further this venture ahead. A brief slide about the project objective. Non-communicable disease nearly takes 62% of the mortality, what is happening in India. And the whole of the idea behind this particular program is to develop the felt need informed choice at a consumer level, and to enable the medical voices so that advocacy, as already told by my colleague, Dr. Rashmi, can be built up around, and regulatory authorities have an informed evidence-based document to take up the front of package labeling. With this, I again hand over the mic, and I'm thankful to AIIMS Bibinagar for all the support and everything. Thank you.
Thank you, sir. Thank you very much for explaining the objectives of the webinar. Now I request our beloved Dean, Dr. Rahul Naran. He is Professor and Head, Department of Microbiology and Dean of the AIIMS Bibinagar, Hyderabad. Sir, please address.
Thank you, Dr. Bhushan, dignitaries in this room and across India. Dear friends, today's topic for this webinar, front of pack labeling and children's health. So when we talk about front of pack labeling, that means we are talking about choices, and we are talking about healthy choices that the persons in this country or across the world can make while choosing their food. Question arises, how many of us get a chance to make choices? Starting from origin of humankind, initially we were gatherers, then we became hunters. And ultimately, we started having food that included both vegetarian as well as non-vegetarian food. Then came era of processed food, and now we have highly processed food. And this processed and highly processed food that is making an impact on human lives. This food, which we can say is apparently non-healthy, is leading cause, as Dr. Vikas Bhatia said, for non-communicable diseases. Now, the consumer and industry, there has to be a balance between the two for the consumer to make a healthy choice. FSSAI makes regulatory guidelines. Before that, the UN in 2015 made guidelines for sustainable development goals that there should be prolongation of health, and that can be because of by adding healthy food to the diet. Recently, United States said that salt, including that sodium chloride content, has to be regulated. But the thing is that labels which are there on the back of the pack, they mention something, but that is beyond understanding of normal citizen of this country. So the front label has to contain something. Presently, what they have is whether the food is vegetarian or non-vegetarian. But again, if the person is colorblind, that circle doesn't make any sense. So now they are going for a triangle with green color in it. So things are happening, the regulations are changing. They cannot be standardized everywhere across the world. Probably in the country also they cannot be standardized. So there has to be guidelines for the south or east, west, and north. And this forum, which comprises mainly of clinicians, has to work in tandem with other fora from common people and make an advocacy for FSSAI to make such labels that are understandable by people across the country. So I give my best wishes to organizers of this webinar, and thank you very much.
Thank you, sir. Thank you very much for your inaugural address and throwing light on this important topic. So now we will proceed to scientific sessions. We have along with us eminent speakers from prestigious institute like Vikas Bhatia sir, Dr. L. Larappa, he is a scientist F in NIN Hyderabad. Dr. Sumati Swaminathan, she is associate professor, Division of Nutrition from St. John's Research Institute, Bangalore. And Dr. Madhavi Bhargav, she is associate professor, Department of Community Medicine and deputy head for Center for Nutritious Studies in Ennapoya University, Mangalore. Before proceeding to scientific session, I request all participants to fill the pre-test form, which is shared in the YouTube link. And at the end of scientific session, you have to fill the post-test form. So, first session is by our Honorable Director, Dr. Vikas Bhatia sir. Sir's topic is childhood obesity and faulty food consumption. Before proceeding, I will give his brief introduction. Dr. Vikas Bhatia sir has joined as a director, All India Institute of Medical Sciences, Bibinagar, Hyderabad, since May 2020, and he was a founder dean in the AIIMS Bhubaneswar from 2012 to 19. He also started eminent journal, Indian Journal of Community and Family Medicines, under aegis of Ministry of Health and Family Welfare. And sir has served in prestigious institutes like PGI Chandigarh, VCMS Delhi, Government Medical College Chandigarh, where he has played key role in establishing Department of Community Medicine and US Urban Health Training Centers. So he has also worked as a National Professional Officer in the UNICEF for UP, and during this mission, he has made significant contribution with the government of Uttar Pradesh in the field of immunization, creating network of health and nutrition resource centers, introducing new vaccine, that is Japanese encephalitis, and again strengthening the maternal child health in the Uttar Pradesh. Sir has been awarded with and honored by the UNICEF as well as Ministry of Health, Government of India, and by the other organizations. Sir is having more than 155 publications to his credit, and he is author of 2 books, and he has completed more than 52 projects, funded projects, and he has made enormous contribution in the academics and public health through the more than 300 presentations in national and international conferences, and he has dedicated his work and contribution to his mentor and teacher, who is known as a Badi Behenji, late Dr. Sushila Nair, and he carries her vision in the reaching out to the poor and enhancing academic environment in India. Sir, we are very lucky to have you as one of the speakers. Now I hand over mic to the sir.
I kindly request all of you to kindly fill the pre-test form and post-test form, very much necessary for your certification. So kindly fill the pre-test form. It is in the YouTube link.
Okay, thank you, Dr. Bhushan, for introducing me and reminding me that what I have done in last few years. And over the years, you just have memories, some good and bad, that what you have done in last 30, 40 years of your professional career. The last thing which you mentioned, that I dedicated my professional life to Badi Behenji. Behenji was the Health Minister, Union Health Minister of India in 1952 to 55. And she was the personal physician of Mahatma Gandhi. Now, to carry this legacy forward as a public health professional is something, a big responsibility. National leader like Mahatma Gandhi, who brought freedom for us, a person who tried to bring the public health in the forefront, and then being a student of such a eminent professional, it is always that we take it further, and our students, our colleagues, and we all work together to ensure that in this time, particularly when COVID has also made this realization across the world that how important is public health in terms of controlling pandemic and also how we can contribute as a professional in strengthening the health system. Now, the topic which has been given to me, particularly on our national webinar on the topic of front of the pack labeling and children's health. The topic is childhood obesity and faulty food consumption. As I was mentioning, next slide please. I can see from here. Yes. Which one? This one. Okay. Now, just to make the beginning, and some of the delegates who are on board at this stage, to remind that the obesity and overweight in general terms, everyone knows, and all educated people are very, very cautious about it. And many of us are also overweight and obese, including myself. That's the accumulation of the excessive fat which impairs the health. When it is under 5 weight for height, overweight is more than 2 standard deviation, and obesity is 3 standard deviation. And when it is between 5 and 19 years, that includes the adolescent age group, this is 1 standard deviation and 2 standard deviation. We all are aware that the prevalence of the obesity is increasing day by day. If we see the data over the years, we'll find a very clear trend of the rise in the obesity. And if we start tracking it down, the age group, we'll realize that now obesity is very common in children. The changes which have taken place in the last 30 years, 20 years, now those children are now adults. When the computers became the part of our lives, now the smartphones are a part of our life. When the books were replaced by those tablets, when the lifestyle from the outdoor games to indoor games, so the eating, the market, the way of life transformation, this has all been responsible as some of the determinants and the social and economic changes which took over in the country and which has given more money to us, to the people, has led to many more things. Half of the people, children who are overweight are in Asia. When we talk about the Asia, and this is further particularly high in the low and middle income countries, and that too, initially it affects the urban settings. Different data, different studies have shown variable range from 4%, which is said to be existing as obesity or overweight in 75, has risen to about 18% in 2016. So these are some of the figures, and they vary from place to place and from within the state also, from region to region, depending upon the socioeconomic status. Now, different studies have shown, some more studies in India, that under 5, the prevalence is around 2%, in more than 5, over 5 years, this is between 2 to 8%, and more in northern and eastern states. And in adolescents, this range is between 3 to 24.7%. It means that at certain places, 1/4 of the adolescents, they are obese or overweight. So different studies, you will find even the NFHS score has reported 4% in the age group of 15 to 19 years. I'm just sharing you with one of the work which I did about more than 20 years back, when in the morning, in the address, in the beginning I mentioned, I'm sharing with you one of the experience, one of the early studies in India, which will highlight some of the issues which we are talking today. There was a national conference of IAPSM at Sevagram. I presented a small project there, and I said that I want to do a study in Chandigarh on the eating habits, primarily to understand the prevalence of obesity and understand what are the adolescents eating in an advanced city. I still remember the panel of judges, they started laughing. And they said, that's Dr. Saab, I was young assistant professor that time, that in this country, when we are talking about the malnutrition, why you are bringing this undesirable issue of obesity and overweight. I said, this is something which I see in my city here. And I tell you that this is going to increase and reach even the Sevagram 2 decades later. And in any nook and corner, any part of the country you go, you will start finding these changes. I'm sharing with you some of the work which I did in 2002 and 4. Then I joined UNICEF, and possibly it got delayed for my publication. This is one of the, Chandigarh is a union territory, has got 113 schools. I covered in that study, this is funded by the Department of Science and Technology, 102 schools, 54 were, these were urban and 33 were private and remaining were the rural areas. So that the population is 17% in rural areas, about 57% in urban areas, and 26% in private schools. And that includes some of the convent schools and high income group where the children usually they are admitted in these schools. And the age group is 12 to 15 years. This was an intervention study where I wanted to bring the change in the eating habits and the menu and their lifestyle of what they eat and what they should eat. And that intervention reached to 32,500 adolescents in Chandigarh. At that time, the population of Chandigarh was about 8 lakhs. And 18,414 I reached directly to in these schools, and through the peer educators whom we trained, another 14,000 were trained. So the gender was almost equal. Now, what were the findings which we observed? There were more vegetarians in the urban and the schools and even in the private schools. One of the big issue is that these children, now the mothers are also working and father is also working. So the children, they don't want to cook in the morning, and they tell their children that you go and there is in the kitchen and you please eat and go. And even if they get up in the morning at 6 o'clock, these children are not keen in carrying the tiffin to the schools, and they don't eat anything. So this is a very important and challenging situation at that time, which I observed within the classmates of my children who were in the school time. Hot dogs, cold drinks, samosa and patties. These were the most common items which were consumed by the adolescent. They are the class 9 and 10 students. These are the commonest, and you can see that how these things are available easily. And you go to any canteen in North India, you will find all these 4 items are essentially required as if they are required for admission in the school and the birth certificate. So this is something like there cannot be a school existing where there is no hot dog, there is no cold drink, and patties and samosa. And when we asked the students, what do they like? They said, we are very fond of junk food. Now just imagine, this is something 1 year back, 2002, about 20 years back. Samosa, they say they love samosa 42%. And I know, I love samosa here as well, and everyone knows here. So, but I have to control my emotions and taste. Tikki chaat, 40%, noodles, which was becoming a fashion that time, and Maggi and all kind of noodles. And pizzas in Chandigarh were very, very, outlets, Pizza Huts and many more were coming up. So 1/4, these were the food items which were very much preferred that time. And 65% of they agree and they understand that these are the junk foods which are very harmful for health. The adolescent knew, but still the taste of these food items, that is so good that they cannot ignore, they cannot, manage without them. When you look at the anthropometry, the status, sometimes I used to think that why we don't get medals in Olympics. If I see a place like Chandigarh, it's 70% adolescents are underweight, 71% has less height for their age, and 52, half the population in an advanced city is adolescents are below normal their BMI. And so just imagine the 2/3 of the adolescent who are expected to be the most energetic and winning the medals in the Olympics, they are underweight. And the remaining, who we feel, the remaining 30% or so, they are entering into the obesity. So where are the healthy people who will run for the medals, who will save our, serve our country in different areas? Where is a good health? That time, the prevalence of overweight and obesity was 9% in the rural adolescents, 8% in urban population, and 14.8% in private schools. Just imagine the 15% of the adolescent in 2002, they were already obese. So which must have been started even before my time of my study. Even the anemic children are also, they are very high, the prevalence of anemia. So another area which we need to address is labeling. When we say we put the label on the food items which are packed, what to do for the food items which are sold on the roadside, such as tikki chaat, pan, papad, papri, whatever you want to do. I've forgotten, I have not eaten a long time now. And golgappa, pani puri, and many more things. I went to Bhubaneswar recently and I was told, sir, you want to have pani puri, there is a very special place, you can go there. So where are you going to put this label? On the mouth of the golgappa, or on the front of the tikki chaat, or on the face, forehead of the tikki wala, or the redi? So you please look at these areas, because people who are poor and people who are very rich, they all go to the same place for enjoying this. The best place is you can go to the lane beside the UPSC where all these items are served, and that is one of the famous lanes in New Delhi, and very popular throughout the country. Another interesting was that the culture of going to the fast food centers and restaurants and eating joints was also rising. Earlier on, there was very little competent concept of going and eating outside the eating joints and now it became a fashion that families with their children, they have to go on weekends and spend weekends going to some restaurant, and housewives, for that matter, even the husbands, they don't want to cook at home. I usually avoid these biases, and they don't want to cook on the weekends. They say the kitchen is closed. So that has led to the more and more opportunity to eat these things. And students, particularly adolescents, when they are exploring their lives, they love to go to restaurants with their friends and newly made girlfriends. In private schools, 69% of them, they went to the restaurants and eat these food items, and which was 30% in rural areas and about 47% in the urban areas. Even 37% of the population, they started observing the fast as a culture, as a religion, or as part of reducing their weight. So they don't want to eat anything, and so this prevalence was also quite high. Now then, I, understanding this issue and a problem, intervened, prepared the technical material, started training the schools, prepared the group of the peer educators, and visited all 102 schools plus the 6 which I did in the initial study. In all 113 schools I visited out of 113. So these schools were covered up, identified the teachers in science teachers in the schools, trained them, and even my team of the social workers and others, resident doctors, they started going there, and we prepared presentations that time. And gave the books and technical material and wanted to see. So this led to some change. After that post-test which we did, the number of students who 1/3 were not bringing tiffins to school, more than half they started bringing. And even the canteens, I told them that what you eat in the canteen is unhealthy. That reduced from 24% to 60%. And the preference over the fast food, which they were having over their balanced diet, the food which is prepared at home by their mothers and their grandmothers, it also, their preference came down, increased for the regular meals, and they reduced for the fast food. I also try to make the change as a policy matter, discuss with the Chandigarh administration, and ensure that the food which is available in the canteens is only healthy and the fruits are available, like we have fruits in front of me today at this seminar. And ensure that the cold drinks are banned and those things which are healthy in nature are available. So these are some of the other improvements which we observed, and the knowledge which we gave to the students and the teachers. This we saw. I'm just giving only some certain areas, but there are a lot of many more items which were intervened and studied. Another area, when I reached to the tribal area in Odisha. Now I share with you one of the studies of the advanced city having the highest per capita income, highest number of mobile phones per capita mobile phones, highest number of cars in the country per capita. So moving from that to another stage, Odisha, and that too in a tribal population. Now in 2018-19, for the first time, ICMR decided and they constituted a task force and they wanted to understand what India eats. Till that time, till the 2015, 16, 17, nobody thought what we eat. जो खिलाया हमने खा लिया, क्या खाया हमको पता नहीं, हमको जो खिलाया हमने प्यार से खा लिया, right? And therefore, the government of India, ICMR, decided a nationwide 14 institutions, and one of them was at the AIIMS Bhubaneswar, where the only institute, the only place where the tribal population was, studied. We have visited and we prepared the list of the local food items which usually people eat in Odisha, and particularly in the tribal areas. We took samples, and so these were, we wanted to see the changes in them, the non-communicable diseases because they are catching up. So we wanted to compare what's happening in this in the remote area of the population, and we took up the tribal population of Kandamal. Kandamal is a tribal population, and is also called as Kashmir of Odisha. Is it so? Yes, there are 2-3 Odia people sitting with me. They are smiling. And also another was tribal area near the Cuttack district. So 2 blocks. Daringbari is particularly, specifically Daringbari is supposed to be untouched area in Odisha, which is very beautiful, and it is called Daringbari is called very beautiful Kashmir of Odisha. And Tangi Chodwar is a place which is close to the Cuttack area. Cuttack is like, this place is around 120 kilometers from the city capital of Odisha, Bhubaneswar. So we covered this, and in each village we covered. Now, what was the interesting thing is, if you compare these 2 tribal populations, this has been published, this work. Daringbari block, which is the remotest of the remote area in the Odisha or in our country, and another is called the Tangi block near the Cuttack. Cuttack is a city area close to the Bhubaneswar. There are a lot of industries. Now Daringbari is a hilly area, and this is coastal area. The percentage of population we can see is 67% and 11%. The major change which I want to highlight here is that why the rise in the economic status leads us to non-communicable diseases. The income, because people were primarily working in the forest area, they were going to the traditional area, healer, and were earning only 150 rupees. And when they went to the Cuttack area, there were a lot of industries. Their income increased by three times, thrice. They were going to industries. Now what happened? Let's see. The same tribal community, how it changes. This is the information which I want to share. And this sample collection we used to transport to by air because we had a good funding from the ICMR, the best of labs which were identified by ICMR, and the food samples were sent to the NIA and Hyderabad from Bhubaneswar at that time. Now you see the random blood sample, sugar. It is 2.3% in the remote tribal area, and it is now 17% in the tribal area which is close to the city, which is becoming industrialized. The level of triglyceride increased from 15%, it doubled in the another tribal area. And the cholesterol from 5% to 12.8%, 2.5 times rise. Now these are some of the I'm sharing with you the important, and what is happening here is we are transforming even our tribal population into the non-communicable diseases. I shared with you one example of a city in Chandigarh, and now within the same state, a tribal population and also the tribal population in two areas. So this is how we need to understand that why this is and what is happening in our country. So this possibilities of increase in RBS, triglyceride and cholesterol is elevated even within the state. We move from one to another place and just imagine that what happens. Now what we are doing is we are creating an environment around us where we are forced or we start loving that environment because that looks very attractive. When we find that the bodybuilders or the superstars, they tell that when they eat these things, these snacks, these soft drinks, they become very intelligent and superstars. That really attracts the adolescent because they are just beginning their new life. There is a beginning of exploring the new way of life. So this needs to be stopped. Snacks, soft drinks, sponsorships, and you see that any university or college programs, they are always sponsored by Pepsi and Coca-Cola. So please see that we do not fall in that trap and we are very careful about it. The second part is the education and information, which we see that is so important change in our culture. People should understand that, it's like not having the breast milk and shifting to the bagged milk is something which is changed. People feel is more fashionable. It's the same thing that something which is food items, they feel that it's like we are more advanced and we are more Western, and people see that we are very smart. So that's we should tell them. And similarly, the sports facilities have also been reducing, and particularly in the adolescents, when they prepare for the NEET exams and JEE exams, they are sitting and all the time, and parents, and you see the adolescent, any coaching center, you will find that maybe the 90% are not only obese, they are super obese. And the changes in the family, of course, their eating habits, their cooking skills, and some genetic predisposition. So this is all what is responsible. And this is how the culture which we see the change. I was in Lucknow when we had one television, and the entire township used to come there to see that movie on Sunday. There was one TV. But now every room has a TV, washrooms have the TVs, and nobody wants to move from one room to another room. So anything is available at home. So children are becoming obese from mild to moderate to severe, and these changes are taking place and they are resulting into the various diseases which you all are aware. So these diseases obesity leads to the insulin resistance and dyslipidemia, hypertension, asthma, sleep problems, and fatty liver, and leads to, now we read, even the early puberty, menstruation has come down, and also leads to various psychosocial issues, depression, anxiety, and social isolation. So when we say faulty food, there are three things which should come in our mind. One is the junk food, the other is the fast food, and third is the instant food. Now, what is the junk food? These are the early energy dense food items which has got high sugar, fat, salt content. This exactly was the name of the project which we did with the ICMR. We identified those items which are high in sugar, high in fat, and high in salt. That was the project. And we all know burgers, pizzas, chips, and chocolates.
ice creams and soft drinks. And this, I have never taken soft drink in my life. Maybe forcefully I was given once in school time. After that, I never took, and I avoid pizza. Yesterday, I took pizza after 2 years. Okay, and I didn't like it. Junk food is what is sold in the restaurant or store. Junk means kachra. Junk hota hai kachra. And kachra जो है Western country का हमारे देश में उन्होंने भेज दिया. People are becoming over or very cautious there. They have put 10%, 100%, 200% taxation there. So they are finding it very costly. So what they are doing it, they are sending it to developing and underdeveloped nations like us. And they are, they're some kind of addiction also. They are addicted. The fast food which is sold in the restaurants, and they are quickly served in packed foods. And in Indian fast food includes pakoda, samosa, namkeen, fries, burgers, patties, nuggets. Some of them regionally how they are prepared and made. Somewhere it is vada, and somewhere it is something else. Here also we eat a lot of fried food. And then we have the instant food when we stand on the road and get immediately instant food which is get dissolved, like the Maggies or the cornflakes or soup water or anything which is given, and you put it into the water and you consume it. What are you eating, consuming? Nobody knows. What happens inside? So what is happening is high salt, high sugar, high calories is leading to early obesity, dyslipidemia, glucose intolerance, hypertension, heart diseases, and nutritional deficiency. So what should be done? What should be done? We did something earlier. I shared with you some of the experiences. First is, please tell your children yourself. First, let us all control ourselves. You see that this samosa is banned. Interestingly, I sometimes feel samosa is one, food item which is available any part of the country. It has multiple names. It's called tikona in Maharashtra. It's called samosa in Chandigarh, and also same name is given in Telangana. It's the same name, and in Odisha it is called as chigada. So, but the content of the samosa can vary, and salt content, the oil content is high. So please be very conscious and stop taking the unhealthy food items. Then we have to see that nutritional education is given. We spread this education in the schools itself right in the beginning, so that our adolescents, they do not become obese. It is the first primordial prevention, so crucial and so important, which we teach our students. We must implement and execute it. And then is the preconception and pregnancy care. Then what we are talking is the nutrition labeling is one of the areas which needs to be highlighted, because now the culture of the buying ready-made foods and packed food is available easily, so we need to address that. And fifth is the health, nutrition, and physical activity for school children. We have made every effort that our students here in AIIMS Bibinagar, they do not sit inside the hostel after the classes are over. They should go out, must play. We have to regulate the marketing of the country, because these are the big players, big fish, big money, so not easy. So these are the things which we need to look at, including the media advertisements, which we must see that they are discouraged, and our youngsters, our adolescents and children, they do not get addicted to these items. So we need to work on the FOPL. We need to address to the policymakers as a public health policy. We need to do a lot of advocacy in the schools, in the institutions, the organizations, IAPSM, CFM, and IPHA. These are the organizations, IEA, and many more other, IAP, and many more organizations should join hands. We work together, we bring change in our lives, in our own families, in our own neighborhood, and spread this message that otherwise this is what is happening. The size of the television is reducing, and the size of the human being is increasing. So ultimately, the weight on the earth is same. If the average of food is same, there is no change between 1990 and 2017. But otherwise, you see how the gentleman was so cheerful and slim, and TV was so thick. That's true. That's that. Even I have the same TV available in Chandigarh, and I was like this in 1990. And in 2017, this is my picture. This has happened to me also. Thank you very much.
Thank you, sir. Thank you very much for enlightening us on the childhood obesity. And we are very surprised to know that the topic which we are highlighting in 2021, that you already started working on that topic in 2002 and 4, and you are done excellent research on this area, and your research findings and suggestions are very helpful, and I think they will be very helpful for the future policy making and guideline making. And you should raise by you, sir, regarding the FOPL and street food. That will be surely we will take care in the future, sir. Thank you, sir. Thank you very much. Now I proceed to the next speaker. For the next speaker is Dr. Ian Agarappa. He is scientist here in the Division of Public Health Nutrition. He has done his MBBS and MD from prestigious institute, Osmania University and NTR University. He has about 23 years of research experience in the field of public health nutrition. His area of research interest is community studies with respect to micronutrients and genetic nutrition and non-communicable diseases. He has published more than 80 scientific papers in national and international journals, and he has published 8 book chapters. He is a faculty member for courses like MSc Nutrition, PG Certificate course in Applied Nutrition, which are conducted by the AIIMS, and he is actively associated with the regular training programs conducted at the institute for the various projects, state units and the central government unit programs. So I would like to invite Dr. Yandarappa for his talk on overweight, obesity trends in India. Sir,
Thank you for the nice introduction. Sir, can you give me opportunity to share the screen? Okay, can I share? Yes, sir.
Yes, sir, you can share, sir.
Good evening to all respected dignitaries. Dr. Vikas Bhatia, sir, Director AIIMS. Dr. Hemlata Madam, Director NIN. Dr. Neeraj Agrawal, sir, HOD, Department of Community Medicine, AIIMS Bibinagar, and all the organizing committee members and the co-speakers. I am very thankful to the organizing committee for giving me this opportunity. The title of my presentation is Overweight and Obesity Trends in India. Though it is a topic on childhood obesity, I am touched all the age groups of population based on the different studies carried out in India. As you are aware that India has been struggling with persistent problem of undernutrition for decades. But now India is experiencing double burden of disease, that is undernutrition, which consisting of underweight, stunting and wasting, which consider about half of 42% to half of the world's undernourished children are living in India. And same time, largely prevalent hidden hunger, that is multiple micronutrient deficiencies, particularly vitamin A deficiency, iron deficiency, iodine and zinc deficiencies. On the other hand, high prevalence of overweight, obesity, and related non-communicable diseases. The causes for this double burden of disease is sequence of epidemiological changes. It consists of 3 transitions. One is the nutrition transition, that is shift in dietary patterns or dietary choice of the population, which leads to consumption of high sugar, high fat diets, and processed goods. Similarly, the epidemiological transition, it is a change in disease burden, that is shift in infection and undernutrition disease in the past to obesity, and it's related to NCDs, the current status. Demographic transition also contributing to the double burden of disease. We are shifting population structure and increased lifespans. This is leading to change in population pyramid, that wide base of youth to a more rectangular shape of an elderly population. We are experiencing this transition currently. The elderly proportion of elderly population is steadily increasing in India, containing to significant proportion of the Indian population. This has resulted in intergenerational change in dietary quality and quantity of populations, and combined impact of these three interventions, that is nutrition transition, epidemiological transition, and demographic transition, leading to a coexistence of undernutrition and overweight obesity. That's why, in spite of all the national and nutritional international programs have been in operation for more than 5 decades, still our global hunger index is not changing desirable levels. Still, it is a pathetic situation over a period of time. Though there was some discussion with the validity of this index, still since the WHO, this is followed by uniform criteria to categorize the countries for this global hunger index. The current one is now our ranking is 101 among 116 states. Even our neighboring countries, poor states, are faring well compared to us. On the other hand, it is a obesity also prevalent, where because of the intake of processed and junk food intakes, as well as carbonated beverages consumption. Obesity is a imbalance between the calorie consumed and calorie expended. It is the interplay between the genetic and environmental factors. The environmental factors include nutrition transition, physical inactivity, that is sedentary lifestyle, changing modes of transportation, and increasing urbanization. All these are contributing to significantly to the burden of obesity. Similarly, adiposity is highly heritable, which contributes 60 to 80% of the body weight, 40 to 77% of body mass index, higher body mass index, and 31 to 76% waist circumference and waist hip ratio. Likewise, the high prevalence of genome-wide association studies conducted in Western countries after 2017 have discovered more than 100 chromosomal loci which are associated with obesity. Thus, there are the contributing factors are environmental factors and genetic factors. The rising prevalence of overweight obesity is the major driving factor for non-communicable chronic diseases, accounting for 44% of diabetes, 23% of ischemic heart diseases, and 7 to 41% of certain cancers. Similarly, high metabolic prevalence, particularly in the South Asians, is contributed by the central obesity. All of us are aware of the consequences of overweight obesity, ranging from different diabetes to cancers related to breast and colon cancers. This picture shows the relation between the BMI and cardiovascular disease mortality. As the BMI increases, the mortality rate is increasing. This is a clear indication of adverse impact of the raised BMI on cardiovascular mortality. Similarly, as per the latest CNNS survey, prevalence of pre-diabetes among adults aged 5 to 9 and 10 to 15 years in India. So see, almost all the states where the prevalence is ranging from 5% to more than 21%, the pre-diabetic, that is fasting blood glucose 100 to 126 micrograms per deciliter. It is in 5 to 9 years age group. The picture is even worse in the age group of 10 to 19 years. Apart from adult obesity, childhood obesity is another rapidly growing public health concern worldwide and is one of the major determinants of non-communicable disease during the adulthood. It has been estimated that 10% of school-age children worldwide are overweight, obese, and childhood obesity is an epidemic in India with 14.4 million obese children India is second highest number of obese children in the world next to China. You can see that the pattern of increasing the childhood obesity. A recent systematic review reported the prevalence of childhood overweight obesity as 19.3% in India, which is increased from 16.3 reported in 2001 to 2005. Even some private schools, the prevalence is 35 to 40%. The same systematic review of 52 studies from 16 states on prevalence of childhood overweight obesity revealed that childhood and adolescent obesity was higher in North India as compared to South India. It reported that in under 5, the prevalence of obesity is below 2%, and children above 5 years is 2 to 8%. Overweight rates are around 2 times higher as compared to the obesity, and is more common in the northern and eastern India as compared to southern India. Similar same review has reported that the prevalence of overweight varied from 3 to 24.7%, and obesity ranged from 1.5 to 14%. In almost all studies, slightly higher prevalence of overweight obesity was reported among boys as compared to girls. Similar pattern was reported in other studies also. Regarding childhood obesity, Kadlikar et al. Reported that overweight obesity among 2 to 7 years children of 5 zones in India is 18.2% as per the IOTF classification, whereas it is 23.9% as per WHO classification. While as other study reported that 25.3% overweight obesity in Punjab, while the same corresponding figure was 14.1% in Karnataka. These are the various studies carried out in India. These are all smaller sporadic studies, or district level, state-wise representation only, except for Kadlikar study. You can see the prevalence is almost all the studies reported is high prevalence of overweight obesity. Particularly the prevalence is high reported by Kadlikar, Chatterjee, Umesh Kapil, and Pandey and Vaidya. You can see even an NIN studies also reported high prevalence of overweight obesity. Dr. Lakshmi et al. Reported this here. I am presenting the findings from the periodic NNB studies. I chosen 3 studies carried out in a tribal area, rural areas, and urban areas. A tribal study was carried out in India, latest tribal survey in 2009, whereas in the latest rural survey carried out in India in 10 states was 2012. And the NNB also carried out urban survey in 16 states of India during 2017. You can see the pattern of overweight obesity. The pattern is increasing from tribal to urban. The prevalence is low in tribal areas where it around 1%, where it goes to 4.3% in 2007 among urban children. Similarly, among the NNB surveys, the age group of 5 to 19 years, the prevalence is of overweight obesity is relatively higher in this age group as compared to their counterparts in girls. The prevalence of obesity is high with 8.1% among urban boys as compared to 7.2% in urban girls. The prevalence is low, as I reported earlier, the prevalence is low in rural and urban areas. The NNB survey, the same surveys, the prevalence of overweight obesity among 10 to 13-year children. The similar trend was observed here, where the prevalence of overweight obesity was reported to be relatively higher among urban boys as compared to urban adolescent girls. But the picture is reversed here. The prevalence is higher among adolescent girls compared to adolescent boys among the age group of 14 years to onwards. You can see clear change compared to previous one. In the previous age group, the prevalence was higher among boys, but it is reversed from this age group. The prevalence of overweight obesity is relatively higher among girls. This is study for the NNMS study, non-communicable disease monitoring survey study carried out in 2017. It is a pan-India study. The prevalence of overweight obesity in urban children is about 12%, whereas it is the corresponding figure for the rural area is 3.6%. Here, in this age group, the boys are relatively higher in terms of overweight obesity as compared to the girls. This is the prevalence of overweight obesity among adolescents by states. It is a CNN study reported, a recent CNN study, 2016 and 18. All India picture of pooled overweight obesity is 4.8%. It ranges from 1.9% in Bihar to 14.4% in Tamil Nadu. Higher prevalence of overweight obesity reported in the states of Goa, Delhi, Arunachal Pradesh, Kerala, Andhra Pradesh, Sikkim, like this. The prevalence is higher in the states. The same CNN study, prevalence of overweight among Indian children. This is the urban study, the urban data. The prevalence is clearly very high as compared to their rural counterparts. At the same time, this is the rural, this is the urban prevalence. The same time, by taking the age group into the gender into consideration, in this age group, the prevalence of overweight obesity is relatively higher among boys as compared to their girl counterparts. This is overweight. In terms of obesity, you can see the obesity is 0.9% in the 10 to 14 years group in rural areas, whereas it is 2.5% in urban children. Similar pattern was reported. The prevalence of overweight obesity was relatively higher among boys as compared to girls. You can see the trends in prevalence of this is obesity in India and other WHO region countries. In general, various studies reported the overweight obesity at 3.8 to about 5.2% in India, whereas other countries in the Western world pooled is about 21%. Though we are relatively lower, significantly lower in the prevalence of overweight, the trend is slowly increasing. We have to take more measures here to contain this. Otherwise, we will reach this stage. This overweight obesity is highest in the regions of Western Pacific region, 33.7, 31. This is alarming pictures are there. Still, we are far below compared to these countries. We have to take measures at this stage only to contain this pandemic. This is the adults, overweight obesity trends in adults. As I reported earlier, we did the three different studies in tribal, rural, and urban areas. The prevalence of overweight obesity, we considered it, we taken as a WHO cutoff point of BMI 25 point and above. You can see in the men, the prevalence of overweight obesity is relatively lower among men as compared to the women. In urban areas, the overweight obesity among men was about 39%, whereas it is 44% in urban women. However, the relative lower prevalence of overweight obesity was reported in tribal and rural areas. This is the latest urban study carried by NNME in 16 states. State-wise prevalence of overweight obesity among adult men. You can see the various states. The prevalence is highest in the state of Rajasthan, Puducherry, Tamil Nadu, and with overweight obesity reported to be low in the states of West Bengal, Uttar Pradesh, Madhya Pradesh, and some at Assam. From all these states, you can see the 33.3 to 42.6. The prevalence is alarmingly very high among adult urban population. The corresponding figures for the urban adult women is picture is even it is more prevalent as compared to their male counterparts. The prevalence reported to be high in the states of Puducherry, Tamil Nadu, New Delhi, Gujarat, Kerala, Rajasthan. In this area, more than 50% of adult women are overweight obesity as compared to their male counterparts. In the prevalence is relatively low in the states of Uttar Pradesh, Bihar, Madhya Pradesh, West Bengal, and Orissa to Assam. You can see the comparison between men and women in all the states except in the state of Bihar. The prevalence of overweight obesity was higher among the females as compared to their male counterparts. The same BMI classification is based on the WHO Asian classification, where we consider the BMI more than or equal to 23. You can see the prevalence is 62.8%. The state of Rajasthan, and higher prevalence of overweight is also reported in the states of Puducherry. Consistently, these states are showing a higher prevalence of overweight obesity as compared to Uttar Pradesh, West Bengal, Assam, Madhya Pradesh. These four states are consistently low as compared to other states. This picture is with respect to the adult females. We can see the up to 74% of adult women are overweight obesity in the state of Puducherry, followed by Tamil Nadu, Kerala, New Delhi, Gujarat. Almost all the states, the prevalence is more than 50%, except the states of Madhya Pradesh, Bihar, and Uttar Pradesh. This is about the Asian classification. You can see the comparison between men and women. As reported in the WHO classification, the trend was more or less similar, where the prevalence of overweight obesity was higher among the females as compared to the males, except in the state of Bihar. This is the NFHS 3 and NFHS 4 data. You can see the trends in the prevalence of overweight among rural Indian adults. You can see this one NFHS study. The prevalence of, as age increasing, the prevalence of overweight was increasing in both the genders. The prevalence is higher among the women as compared to the male comparator. Whereas in adolescents, we have seen the reverse trend. Here, with the female are more obese and more overweight as compared to their male counterparts. At the same time, the prevalence of overweight was increased from NFHS 3 to NFHS 4. There was a significant increase in the prevalence of overweight among Indian population. This is the respect. The previous one is the overweight. This is the obesity in the rural population. The same trend was reported where NFHS figures shows higher prevalence of overweight obesity in both genders, and female have more overweight obesity as compared to their male counterparts in both the surveys. This is the urban trend in overweight. As you see in the previous one, as age increasing, the prevalence of overweight is increasing even in urban population, and females are more obese, more overweight than as compared to their male counterpart in both the surveys. This is the obesity trends among urban adults. You can see in the rural area, the prevalence of obesity is 6.7%, whereas it is 16.9%. It has increased alarmingly very high among urban female. At the same time, as compared to previous NFHS 3, NFHS 4 reported higher prevalence of obesity among Indian adults. This is the study report mean BMI among 18 to 69 years age group carried out by NNMS in 2017-18. You can see the mean BMI. You can see the mean BMI of men and women in urban areas is alarmingly very high as compared to their men and women counterparts in rural areas. It is the mean waist circumference in the 18 to 16 years age group, where the men have more than 90 centimeters, waist circumference of more than 90 centimeters, and in women it is more equal to more than 80 centimeters, considered as a abdominal obesity. You can see the urban areas, the mean waist circumference of men is 86.6, whereas their counterparts in rural area it is 78.8%. In case of women in urban areas, their mean waist circumference is 18.23 centimeters as compared to 17.5.3 in the rural areas. This is the BMI classification based on the WHO Western classification, that is BMI 25 and above. You can see in the urban area, a higher proportion of urban adults are overweight or obese as compared to their rural counterparts. Similarly, a higher proportion of females, adult females are overweight, obese as compared to their men counterparts. With the prevalence of overweight and obesity among adults, you can see this prevalence of overweight, obesity, the overweight of 40.2% of adult men and 86% of urban adult men are obese. However, the relative higher proportion of urban women reported higher prevalence of overweight and obesity. Their counterpart rural areas reported low prevalence of overweight, obesity in both men and women. This is as far as the Asian cutoffs, where the BMI 23 and above. As reported in this one Western classification, the proportion of higher proportion of urban adults are overweight, obesity as compared to their rural counterparts. Similarly, a higher proportion of adult women had overweight, obesity as compared to their men counterparts. The adults with central obesity by area of residence and gender. We can see the abdominal central obesity or abdominal obesity is 39.5% in urban men as compared to 58.1% in urban women. Whereas the corresponding figures in the rural areas is 16.6 and 32.4%. The preventive measures for childhood obesity. According to WHO, childhood obesity is one of the most serious public health challenges of the 21st century. Prevention of childhood obesity is vital, especially since the treatment of obesity is extremely difficult. Therefore, we have to adopt the proven strategies to prevent the childhood obesity. They include increased consumption of fruits and vegetables and reduced TV viewing. Eating while viewing TV is a major cause of excess food intake. It was reported by almost all the studies carried out in Western countries and as well as in India. TV commercials also lead to children towards the attraction towards the fast foods. It also encourages children to consume reduced sugar intake. Sugar is called as a new tobacco and must be limited to all age groups. Similarly, encourage the children for physical activity. Parents need to facilitate physical activity in young children. They have to adopt 30 to 60 minutes of daily vigorous physical activity, particularly in the older children. They have to inculcate healthy eating behaviors. Parents need to be ensured that the children eat when they are hungry and not when they are bored or tired. It should be followed appropriately. Other strategies include practice of appropriate IYCF practices should be followed to prevent the childhood obesity, particularly initiation of breastfeeding within 1 hour of delivery and the feeding of colostrum, as well avoiding pre-lacteals. Similarly, exclusive breastfeeding for the exclusive first 6 months of the infant life and initiation of the complementary feeding and appropriate complementary foods by age of 6 months. Similarly, the focus should be on primordial prevention, where all the healthy lifestyles and food habits should be inculcated during childhood and adolescent period to prevent obesity in the childhood and NCDs in the adulthood. Because we have to take care before emergence of all the risk factors for obesity. Childhood obesity is adulthood diseases. With this, I conclude my presentation. Thank you very much.
Thank you, sir. Thank you for a new detailed presentation and throwing light on current situation of double burden of disease and current trends of obesity among the childhood in the globally and India and among the various states of India. So I hope that these findings from your studies will be very helpful in frameworking the FOPL guidelines. Now I move to the next speaker, Dr. Sumati Swaminathan. She is Associate Professor in Division of Nutrition, St. John's Research Institute. She is She has completed her MSc and PhD in food and nutrition, and she has worked as a consultant and dietitian in various institute and hospital of in various places in India. She is a life member of Nutrition Society of India and Indian Dietetic Association, and she has received various awards for the presentation in scientific conferences. As well as she has more than 50 publications, and she is the author of three book chapters, and currently she has three projects which are related to the nutrition. She has also one patent on her name regarding the indigenous therapeutic food for STAMP children. Madam, I expect this will be a very good learning from your presentation, and I hand over mic to you for your presentation. Thank you, ma'am.
Thank you very much. I hope you can hear me and you can see my presentation. I've shared this.
Yes, yes, it's all.
Yeah. Okay, so good evening to you all, and I thank you all very much for asking me to present on the marketing of packaged foods, the nutritional impact on children. I think the earlier presenter has already talked to you about the Comprehensive National Nutrition Survey. And we do have data where it indicates that, there is a very, very low HDL in nearly 26 to 28% of children between the ages of 5 to 19 years of age. And so it presents some of the cardiovascular disease patterns actually are seen even earlier in life. And high triglycerides are also present in quite a few of the children. We also see high total cholesterol and hypertension and overweight. Of course, I mean, this is for all the different states in India, but then you will find that in certain pockets, it is even much higher. So in some cities, you have about 40% overweight and obesity. And between rural and urban, there are some differences. And within the same urban or rural area, over a period of time, there has been a lot of changes, which has led to this changes in the changes in lifestyle have actually resulted in a lot of these changes in these children. And what is one of the important factors is the food environment, because over the past so many years, there has been a swift urbanization that has occurred. So, and it has occurred so rapidly. So if during my childhood days, I never used to see so many packaged foods, but now you find a lot of packaged foods. And there is an increase in use of a lot of processed foods, which are basically convenient to prepare, they're inexpensive, easily available, and they could be served even as large portions, and they're heavily marketed. And for a manufacturer, the food package labeling is important for him because it is used for marketing to promote the products. And also they can put in the health and nutrition claims. So it is basically for the promotion of the product, a lot of marketing claims are made. But for the consumers, the label has to make sense, because if it is interpreted correctly, they can actually resort to healthier choices. And in this whole food environment, it is the child who is most at risk of being exposed to encourage snacking. Now, what you have heard of this term, the HFSS, that is a high fat, salt and sugar. Now we were looking at we have had a few concerns, because nowadays when we go into the rural area or to the urban area, we find that children are actually snacking a lot. And so we try to capture all this by taking photographs and by also recording the 24-hour recalls. So what we actually found was that, so we were looking at a small set of children. We were looking at a case control of, normal versus children with SAM. So it was age and sex matched. And we found that sugar was one of the highest amount of sugar was taken through the snack foods. So you see about 42 to 43% being taken of sugar taken from snack foods, which is bought from outside. And So to come to it, so you have the packaged foods. And so from the 1980s, what you had was the nutrition labeling was mandated. That is, it started with the WHO and the Codex Alimentarius actually coming up with some rules on nutrition labeling. And this was supposed to be an important policy tool for governments so that they could guide consumers to make informed food purchases and make healthier eating choices. And what does food nutrition labeling mean? It is a sort of a declaration. You should have a nutrient declaration. So you have the back of pack, the front of pack, the side of the pack, and which I'll show you a little later. So it would have nutrient declarations. It would have nutrition and health claims. So that depends on the company and what is the product. And again, it should have supplementary nutrition information. And that includes also the front of pack labeling, which in recent years have been advocated a lot. Now, when you say nutrient declarations, you would have seen in most of the back of the pack labels that you have standard listings of the nutrient content of a food or a beverage. And the complexity, there's so much of information at the back that sometimes even with a magnifying glass, I don't think you would know what exactly is there. So to me, it is not so easily accessible and is often poorly understood. And whatever it is, the nutrition labeling has to align with the national public health and nutrition policy. So in each country, it is different. So it has to align itself with the national public health and nutrition policies and the food regulations of the particular country. And it has to adhere to the WHO guidance and Codex guidelines. Now, we had done way back between 2008 and 2010 a study across 16 countries. So we are part of the PURE study, the Prospective Urban and Rural Epidemiological Study. And as a sub-study, we had done what was called as an environmental profile of communities' health. And where we were looking at tobacco, we were looking at the food environment. And so we published a paper on for nutrition labeling, nutrition and health claims. And this was done with just taking one chip packet and one sweet biscuit packet from each country and from each community in the rural and urban areas. Approximately, there were about 20 from each country. So totally, what was analyzed was about 737 packets. And at the time of data collection, nutrition labeling was mandatory in Argentina, Brazil, Canada, Colombia, and Malaysia, while it was voluntary in China, India, Poland, Turkey, and UAE. And except for those which were used for special dietary uses. And in Iran, Pakistan, and Zimbabwe, there were no regulations as to what should be the nutrient labels. So when we looked at the data, if you look at it, Iran and Pakistan have the lowest and with the nutrition labels. And among what was mandated, it is those 7 are required nutrients as mandated. It was only probably Canada which had all the 7. All the other countries did have a lower number of nutrients which were labeled. And the number of packets in India, it was around 73.9% which were labeled. So then coming to the front of pack labeling. So what is in recent years, you have come to have front of pack labeling. Now, for what reason? What is a front of pack label? It is a part of the package that faces forward. That is, it should be in the principal area of vision. And it is the first thing that a consumer will see when they look at a product. So what is generally wanted is a graphic information, so which is on the front of label pack. So you have the traffic light system, you have various systems which are used across different countries. So you may have red saying that it is above a certain level in salt, fat, sugar. And you could have a green which shows that it is within the limits and something as orange. So that is why it is called a traffic light system. And front of pack label actually complements the nutrient declaration. So you're supposed to have that, plus also something which is very easily understandable by the consumer. So in the front of the packs. So what they termed, the WHO termed as the principles of FOPL was that it should be aligned with the national public health and nutrition policies, as I told you earlier. And there should be a single system to develop to improve the impact of the FOPL system. So there has to be a consensus on what exactly has to be the FOPL system for the particular country. And there are certain mandatory nutrient declarations which are also required on the for the FOPL systems. And what is most important is there should be a monitoring and review process, and it should not be just stop with the first first process of developing the product, but it should continue, and there should be improvements and adjustments done as and when required. And it should be a transparent process and easily accessible. So when is it not appropriate? So FOPL is not put on any generally on an infant and follow-up formula. You can't promote that product using FOPL, as these have very strict compositional criteria. And anything that promotes reformulated products are not appropriate. And some foods, packaged foods, are exempt because such foods as spices and condiments are exempt, and also alcoholic beverages. So the FSSAI 2021 has come out with certain regulations. You have it in the Gazette Notification of India. So what is required as food labeling is the name of the food, the list of ingredients, and then nutritional information, declaration, whether it is veg or non-veg. So you have the green with a round in between. So these are the particular ones that have been recommended now. The triangle for non-veg, a brown triangle for non-veg, and the green round for vegetarian. And then any declaration regarding food additives, and then the name and complete address of the manufacturer of packer, the net quantity, code number, lot number, batch number, etc., date of manufacturing, best before and use by date, country of origin for imported food. So we do get a lot of imported food in India in recent years, and so the country of origin also has to be specified. The instructions for use, food allergens, and it should have the FSSAI logo and the license number. So only then should it be marketed. Now, there was a paper in the Lancet by Richa Pandey and then Subbarao and Bharti Kulkarni on the front of package labeling. So what has to be displayed is the total amount of calories, fats, trans fats, sugar, and sodium per serving. So if it exceeds the stipulated limits, it has to be in red color. So, and what originally we were following a 100-gram format, but now it will be a per serving format. For me, the per serving format is a little bit, I'm not very sure what the per serving means in many of these products. Now, their critique was that the concern especially was that in legume-based snacks, it may be red labeled because for fat and salt, but there are certain products like buttermilk, which is a single ingredient product, and it may not be labeled as high salt because it is exempt from the front of pack labeling. So that is one major concern. And how many people actually look at a label? So how many are literate and they look at it and they have a nutritional awareness about it? Only those people can actually understand these packages. And so is it better to have a pictorial representation? That was their critique on the FOPL. Now, there is also a problem with the industry versus the consumer. So what does the industry want? They want the label to be a guideline informing the consumer about the quantity of salt, sugar, sodium, and fats. So it is without a health warning, but the aim should be to enable consumers to make an informed decision and not discourage them from the consumption of packaged food. But what does a consumer or an advocacy group want? They want to know whether the food is healthy or not, and whether it is good or bad for the health, and if only the quantity is specified. So if you look at the quantities which are at the back, is anyone able to actually figure out, because of this much of nutrients, that you're supposed to eat this much or you're supposed to decrease your intake? It is not so easy. So they want something which will make them realize that are they eating healthy or not eating healthy. And so now it looks like there is a perception study which will be done by the IIM Ahmedabad on this. Now, when we say marketing of foods to children, there was a WHO 2010 resolution which came about, saying that the recommendations on the marketing of foods and non-alcoholic beverages to children were basically to guide efforts by member states of the WHO in designing new policies or strengthening their existing policies on food marketing communications to children. Now, this is a very powerful marketing tool. Food marketing communications to children is usually very powerful. And so for this reason, it should be for the purpose of reduction of impact of marketing foods high in saturated fats, trans fatty acids, free sugars, or salt. And when it's the meaning of marketing to children generally refers to any form of commercial communication or message that is designed to or has the effect of increasing the recognition, appeal, and or consumption of particular products and services. It comprises anything that acts to advertise or otherwise promote a product or service. So it is not just the communication, but it also means its intention. So as you know, children are gullible. They can be emotionally blackmailed into taking things, and so that is one of the concerns on marketing of foods to children. So when they say marketing, what is it? So it is an exposure. So what is the reach of that exposure? How many are exposed? And what is the frequency of messaging? How many times are they exposed to it? Content also determines the power of the message. So the cumulative power of these messages actually results in them in the intake of that exposure is high in SFs or trans fatty acids or free sugars or salt. That is a major concern. So this exposure, they propose that this exposure has to be reduced, as well as the power of marketing has to be reduced in children. So power in marketing communications, it refers to actually the content, the design, the creative strategies that are used to target and to persuade children. So who are the key players generally in these, those who are targeted for this marketing information are manufacturers, retailers, and those who are the key players in marketing are the manufacturers, the retailers, the food service providers, trade associations, and representative bodies. And it could be disseminated through media players and then content or access providers and distributors. In recent years, you find that it is the online websites also that actually are sources through which marketing is done. So what are the methods of marketing? So you have the advertisement, you could have it in the newspaper, radio, TV, online, billboards, posters, in the cinema. And then there is the other way of marketing is through product placement and branding. So even over the media, audio, video, or the written media, you will, and on computer games, then publicity campaigns, then branded books. Example for preschoolers, there could be branded books, branded toys and computer games, interactive websites. All these do have a lot of products being advertised. And sponsorship. So when there is a TV sponsorship or radio events, educational materials, equipment, and then during sports and in different venues when some functions are held, direct marketing, it is by even promotional emails or by phone or by leaflets which are given door to door. And then there could be some contests, discounts, promotional and sampling in schools. And product design is another way of marketing. That is, it could be colors, shapes, toys. And if you look at packaging, it could be majorly colors. Product portion, example, it could be a king size portion, it could be promotions, it could be gifts, puzzles, vouchers. And at point of sale also, so if you go into a supermarket or in different outlets, so it displays all the special offers, the vending machines, then there could be something of loyalty that is shown, or there could be some free samples that are provided. So if you look at in-school marketing, there could be, especially in the high-end schools, the use of vending machines, and then branding of school catering menus. So that also occurs in quite a few places, branding of school signs or stadium signs, use of vouchers. So these are as educational rewards, and donation of branded school or gym equipment, offering of school materials in return for food purchases, and sponsorship of various functions, and also of the school vehicles. So school bus and all that, when it is sponsored by a food marketing company, that also occurs. So how does it impact on a child? Basically, it has an impact on brand preferences and also on food choices and request to parents. So you have what is called as a pester power of children. So they go on pestering for certain foods. And we see it all along in our life now, especially in recent years. And why is it so important that children have to be protected? Is because the cognitive capacity to rationally consider advertising appeals are not really very good. And they will not reject those that are not in their long-term interest. So self-regulatory abilities also are not there for them to resist the temptation of very highly palatable foods. Now, FSSAI has also proposed a ban on all forms of advertising of products with high fat, sugar, and salt aimed at children, but but not really specified what kind of a ban is required, because you still find some of these advertisements going around. Now, the power of marketing, basically, there are some like spoke characters. So when you say it is a spoke character, it is any animated object or character being used to promote a product. For example, some years back, McDonald's had actually had spoke characters with cartoons and licensed characters. These show some amount of fun and appeals to the taste of the children. So if you see younger children who eat home food, they are not so easily impressed by it. But as they go out and they watch their peers, you find them being, even if they are people who do not like burgers, they start taking burgers after a period of time. Advertisement on media, it could be on the newspaper, it could be on the TV. You have all these different 50% off offers, and then the way in which it is depicted is actually something which is the imagery is actually very appealing to the children. And so what happens is the food preferences change, the purchase requests also start increasing, and the consumption patterns start changing. So this cumulative exposure to marketing of foods is actually a major concern. In fact, I don't know about India, but then in most countries, most of the children's programs, actually 50% of the advertisements are on foods. So here I have taken some of what is actually being promoted. So you have the different characters, you have the Pokemon on real, and the color, the type of colors that are used. If you look at Pediasure, how was it marketed? Pediasure, it was the company went directly to the preschools and actually started marketing the product. And you have the way in which there are depictions of the different food items, it is very appealing to the children. And online advertisements are also there. So though we don't realize it, and we do say like Facebook is only after the age of 13, children are still exposed to a lot of online advertisements because they see there, even if you look at preschoolers, they are watching programs on they are watching their nursery rhymes and things on online. And all these also crop up at the same time. So now another concern that I found was that because when we went into rural areas, now the clause 8 of FSSAI regulations 2021, they say that where the surface area of the package is not more than 100 square meters, the label of such packages shall be exempted from the requirement of list of ingredients, lot number, batch number, code number, nutritional information, labeling of irradiated food, declaration of food additives, license number and logo, the name and complete address of the importer, and instructions for use. But these information shall be given on the multi-unit packages. That is what they claim. But I'm not sure how many of you would have gone into the rural areas. We have gone into Karnataka rural, we've gone into Bihar in recent years, and the proliferation of snack foods is enormous now. And if we look at it, it's what has come recently is that nearly 80% of the foods are in as small packs. That is 2 rupees to 5 rupees packets that are available in the market. Now, rural marketing, there has also been, there are several companies which have actually gone around and, promoted the products as a 2 rupee packet or a 1 rupee packet. And they are low priced fortified products or nutraceuticals, which they claim to combat anemia and micronutrient deficiencies. So one of the studies in Andhra Pradesh has actually looked at it. But this boost is what we have seen in Karnataka in small packages. We usually don't see it in Bangalore. What they're targeting is affordable nutraceutical goods for consumers at the bottom of the pyramid. So when we had gone to Bihar, I was amazed by the number of packets that were available. And let me tell you, we have done it in Andhra Pradesh also. Actually, we were also working in the Palamner area. So when we were doing the epoch study, part of this thing is the Palamner area. And we found a lot of these small packets. So if you look at the nutrition label behind, so say something looks like Lay's, it's a chips. What they copy behind is actually the same label as a Lay's packet. So I doubt whether they even, analyze for the nutrients that are there inside the packet. And it is very badly done. So these are the different items that you get. So you have the front of label packets, the back of label packets, and you have different types of snacks. And it is amazing that it is only at 2 rupees and 3 rupees or 5 rupees that they're getting all these small packets, and every child takes it on a daily basis. At least Karnataka was a little less, but Bihar definitely had a lot more. We are still analyzing this data. And when we were doing a school study, we found that at around 10:30, when we had gone along with the ICMR group actually who are evaluating our project. And at that school at 10:30 exactly, a whole lot of women and men came in with a whole lot of goodies. And these were the type of goodies that were all there. And you find it now, this one specifically is from Bihar. These are from, these two are from Palamner area. And these others, we know that these are already there in the market. It's been there for many, many years. But then what is the label on them? There is nothing on them. But this is just a sugar candy. That is all it is. And children buy it by the dozens and eat it. And if you look at this is called a pav bun. And it's a very, very, very hard rusk, which is bought at 1 rupee. And every mother buys it for the child in Bihar. And these are sold in the schools. Now, all in different colors. Some of them are chocolates. Yes, you have even the 5-star ones, which are at 1 and 2 rupees, which are there. So what is it that you will label in all this, and how are you going to give them the information? So it is a nutrition education that is really important. But anyway, these labels, though you may have different labels, it is important in this day and age. We also have to consider what are the other aspects to eating in children, and what are the other temptations that are there. And these also should be addressed. So I end my talk here, and thank you very much for this session.
Thank you, madam, for your detailed presentation and making us audience aware regarding the situation of FOPL in various countries and in India, and its importance and principles. And you also discussed power of marketing advertisement in your presentation, and its role in food preferences and consumption patterns for among the children and adult population. Ma'am, thank you for giving the detailed presentation. Now I will move to the next speaker, Dr. Madhvi Bhargava. Her topic is thinness and stunting in adolescents, finding from NFHS 3 and 4. Madam is currently working as an assistant professor in Department of Community Medicine in Appaya Medical College. She is also working as a deputy head Center for Nutrition Studies in Appaya University, Bangalore. She has worked more than 10 years as a full-time surgeon and clinician in tribal areas of Chhattisgarh, and she has got trained in research at prestigious universities like McGill University, Himalayan Institute of Medical Sciences, and St. John's Research Institute, Bangalore. Her work focuses on primary care, public health in low resource settings, and social determinants of health. Of the social determinants, nutrition and its intersection with communicable diseases like tuberculosis is the major work area whether she is currently involved. And she is also co-PI for a large ICMR supported cluster randomized trial that is known as the ration trial in Jharkhand state. And she has also analyzed national level data for adolescents to identify the important nutrition problems such as stunting, thinness, and tuberculosis in them. Using operational research approach, she has investigated the preparedness in the primary care for nutritional assessment, screening disease severity, and risk stratification for tuberculosis. Maternal diet and nutrition are other areas of work. She has also collaboration with various research institutes like UNICEF, NIN, NIRT, and Karnataka State TB Task Force, and Lady Irving College, Delhi. She is academic editor of PLOS ONE and PLOS Global Public Health Journal. And Madam, this is your brief introduction, and we are expecting a lot of learning from your presentation. I hand over mic to you.
Thanks so much. So are my slides already visible?
Yes, ma'am.
Yeah, okay. So what I will do is I will stop my video to save some bandwidth, if that is okay. And
yes, ma'am, no issue.
yeah, but I'm visible.
Yes, madam, your
My
presentation
slides
is
are
visible.
visible. Yeah, perfect. So the advantage, thanks organizers for having me here, and the advantage of speaking in the end is that a lot of things are already said, so I can skip a lot of things. But yeah, I do not have any conflict of interest to declare. I do not have any endorsements to declare, because this is something to do with food. It becomes very important. So to outline my talk, I'm not going to talk about the marketing tactics anymore, except that some which I feel are very specific to the rural and the tribal areas. I might just repeat some of those things which already Dr. Sumati has beautifully described. But what I'll do is I'll put my case on why thinness and stunting is also important in the context of packaged foods. And I will share my findings, which are a bit striking when we reanalyze the NFHS data on adolescents and how they finally impact the adult nutrition estimates, and give my thoughts on the way forward. So apart from various things that Dr. Sumati already talked about, We are talking about children and youth. So there is a lot of depiction of excitement that is usually shown in most of the marketing, tactics that they use. And there's always this celebrity endorsement that comes with it. So the people, children especially, who are very impressionable, there's a lot of peer pressure. Then there is a trick of affordability. So this 2 rupee, 3 rupee, 5 rupee packets that Dr. Sumati talked about, you'll never find these packets in swanky malls, but they'll always be available in, remote tribal areas, rural areas, in slums, etc. And, we have this, what is fed into our mind is the default combos. So it's a very cumulative exposure that happens. So we never think of, a burger with buttermilk. It will always be a fizzy drink because nobody, suggested it. So we never tried it. And then we'll never know how it tastes. So that's how the combos get, built into our psyche. And then healthier alternatives. So there'll be atta noodles or there'll be no sugar drinks, But it's almost like, a clever mother will ask the child, you want to have milk with sugar or no sugar. So the child has no option about having milk or no milk. But similarly, this tactic is used on a large scale where, we are given healthier choices, but the choices are for the packaged and the processed food. They also make sure of leveraging local language, lingo, and ensure visibility. So, you don't see a lot of bananas hanging these days on the small shops, but you'll definitely see those packets, colorful, shiny packets hanging there. So, why am I talking about, let me make my case for thinness and stunting. So, we all know that adolescence is from 10 to 19 years of age, and it's a period of very rapid growth, matched only by infancy, by its rapidity, dramatic biological, psychological changes. But there's one added determinant, and that is the sense of autonomy that they develop. And there's a very great influence of the socio-cultural and economic milieu in which they grow. So while, we are very often we celebrate that our CEOs of the global MNCs are of Indian origin, there are some grim realities as well. So because the infant under 5 mortality has reduced, more children survive, but they survive to see at times chronic deprivation. And there's a lot of hidden hunger in terms of macro and micronutrients especially. And so there's an internal brain drain that is going on with poor learning abilities, lower immunity, recurrent infections, increased healthcare costs, work performance, and this loss of opportunity. The opportunity cost that is wasted is intergeneration, because the underweight girls will grow into underweight mothers, and they will go on to deliver the underweight babies. So already, 3 speakers have talked about overweight and obesity and touched upon various aspects of it. But it is equally important, when we talk about processed and packaged foods, to address the other end of the spectrum of malnutrition that we see. So when we talk of adolescents, my feeling is that this is one age group that is receives very little importance when it comes to public health discourse. So whether it is surveys at national, global level, or whether even in the family and community level, they become invisible once they are on their own. So these are some of the surveys we have information from. So of course it is NFHS, and I'm going to describe my findings where we have done some re-estimations. But then we also have this global school health survey, health behavior in school age children survey, global youth tobacco survey, and recently the CNNS, the Comprehensive National Nutrition Survey, that already one of the speakers has talked about in detail. So when we embarked on this reanalysis, this CNNS data was not available. So the whole idea that, there is so much of information available on, 500,000 of adolescents in NFHS 3, little less than 3 lakh adolescents in NFHS 4 was very inviting. And we had anthropometry available in almost 50% of them. So, and another thing that is probably important when I describe my findings is that in NFHS 4, we had greater rural representation and little more poorer quintiles that were represented. But otherwise, we know they are the best representative samples. So when we do nutrition assessment, one thing is that up to 19 years of age, everything is sex specific. So we have this weight for age, height for age, weight for height standards, for all age groups. And up to 10 years of age, we use all these three. And then after 10, we don't use weight for age because of the pubertal growth spurt and, the differential in which the weight is gained by girls and boys and various stages. So we have two reference standards, the WHO standards and International Obesity Task Force standards. And we decided to use the Z scores because there are several advantages there. Because one is that they are standardized quantities, so comparable across ages, sexes, and also anthropometric measures. Moreover, because it is available as continuous variable, a lot of information is not lost in categorizing them. And the extreme values which are lost in percentiles are captured here. So what we found is that what NFHS originally reported in 15 to 19 age group, considering these children, these adolescents as adults, was that the thinness was originally 58.1% and 46.8%, almost 47% in girls. And when we reanalyzed, this came down to 22% and almost 10% in girls. And also the severely thin adolescents in both NFHS 3 and 4 came down drastically. Similarly, in FHS 4, it had already reduced, it reported reduced thinness. So from 44.8 in boys, it came down to 16.6%. And in girls also, it was like 42% almost, and it remained static at 9.9%. So these are good, things, and which is something very significant. So we don't have so much of thinness apparently. So finally, we are overestimating in boys almost 2.5 times and almost 4 times in the girls when we when we consider these 15 to 19 adolescents as adults. And of course, there is a lot of subnational variation also. So there are pockets where there is a lot of thinness. In NFHS 3, it was highest in Maharashtra, almost 25% overall. And in NFHS 4, it was Gujarat with 19%. So the start thing was that in NFHS 3, we had 12 states that had thinness more than the national average. And this increased to 16 states in NFHS 4. So when we look at the relative increase, there is, now there are 16 states who are not faring very well. Now coming to the stunting part of the story. And we all know that, it's a very robust indicator of long-term nutrition, and it gets affected to great extent, on individual level, yes, genetic factors do affect. But at population level, if you look at the means, it's a very good indicator of adequate and good nutrition, sanitation, many other developmental factors. So what we saw in stunting was that, yeah, we have had some very good, results about the under 5, where, it is reduced from 48% in NFHS 3 to 38%. And mind you, under 5, girls and boys are faring equally bad or good. The another age group where we have some information is the reproductive age women, where in NFHS 4, there was 10% point increase in women who were less than 145 centimeter. So when we talk of thinness, this is something I really want to stress, and its importance cannot be overemphasized enough, is that when we talk of thinness, we have to see the backdrop of prevalent stunting in our population. So a stunted child or adolescent or an adult is less likely to be classified as thin because of the lower denominator of height. So this is something very important when we talk about thinness and stunting, especially in an age group which is our future adults. So when we looked at stunting, it actually increased from NFHS 3 to NFHS 4. So in boys, from 25%, it became 32%. And in girls, it became from 31, it became 34.4%. So this is a major increase. And of course, this gap is wider, as we have seen also in CNNS, earlier speakers have already talked about. So this gap is wider in rural and poorer wealth quintiles, and I'll show you in coming slides. So it has several serious intergenerational implications, where, in adolescent girls, they are all going to be adults who are now more predisposed to all the possible risk factors of non-communicable diseases. And that is why we have all these problems emerging much earlier in our population as compared to the Western world. And the severe stunting also increased significantly over the 2 surveys. And if we look at the subnational estimates, the stunting was less than 20% in 6 states, but then only 3 states had stunting which was less than 20%. So whether this was a true increase, or, as I mentioned earlier in my slide, greater representation of rural and the poorer quintiles, we don't know. But remember, this is an individual level data that was analyzed. And subnational heterogeneity means that it's a very wide range. So if the stunting was more than 60% in the northeastern states, it was almost around 15% in Punjab, Chandigarh, etc. So coming to similar findings in CNNS, it was again found that stunting was highest at 38% in boys and girls, at the boys especially at the age of 18. And like CNNS, our findings as well were such that there were pockets of double burden of malnutrition. And this is basically existence of undernutrition with overweight, obesity, or diet-related NCDs. So at individual level, we can have obesity with micronutrient deficiency, or overweight adult who is stunted. Or at household level, we can say if there is a mother who is anemic, or a mother who is overweight and has a child or a grandparent in the same household who is either underweight or stunted. At population level, we say that there is a double burden when both undernutrition, overweight exist in the same community, nation, or that region. So anybody who is interested in childhood and adolescent nutrition, CNNS is an excellent resource. For the first time, we have a very comprehensive indicator, all the comprehensive indicators available in more than 40,000 children in the age group of under 5, 5 to 9, and 10 to 19. So there's a wealth of information out there. And now, when I talk of processed food and packaged foods, we have to remember that, it is unhealthy snack for some, but as Dr. Sumati also mentioned, in rural areas and tribal areas where all this is infiltrated in a major way, it is actually unhealthy food for a vast majority of our population. So the proportion of healthy food some of these people are having is very little. And you can see over the various, quintiles starting from richest to the poorest, the stunting is so smoothly increasing. And because of these persistent poor dietary intakes, we have something known as thin fat induced. Dr. Anurag Kupad loves to use this term. Of course, we have stunting, overweight, obesity, everyone has talked about, and NCDs at younger age. So CNNS again has a lot of information regarding the various risk factors right from very early childhood. So when we talk of packaged foods, we need to say who is consuming it. What is the baseline consumption of the healthy foods? And the factors that decide the impact are the wealth quintiles, the castes, the tribes, the urban and rural residents. And and the worst thing is that, what this is increasingly seen in the poorer households, the scheduled tribes, remote villages, etc. So the findings from CNNS in terms of some key consumption patterns are not very encouraging. And there's a lot of consumption of aerated drinks, fried food, etc. Now, coming to the impact of this overestimation that we have been doing all throughout our National Family Health Surveys is that if you look at this graph, once we re-estimate, there is a smooth transition that occurs over the age groups, and we can see how it increases as the age groups proceed. But what it means is that when we overestimate in one particular age group, which is represented in very large number, the whole mean of the population is getting pulled towards this overestimation of thinness. So this means that we are not able to appreciate the impending overweight obesity that is accumulating, and the whole shift of the average BMI of the population that is occurring to the right. So what this is the weighted mean that we have done. So what is 34% becomes 27%. What is 36% becomes 28%. This is this is NFHS 3. Sorry, there's a typo there. And similarly in NFHS 4. So now look at the reduction in the population mean, which means that we are not able to see the shift of the BMI towards the right, and we all know the impact that can occur over a period of time. So when we talk of stunting in adolescence, it's really a lost window of opportunity. And we know that the optimal growth is first in the womb, where maternal nutrition is important, and that is what decides the birth weight. And already some of our children are disadvantaged at that point. Then we have the second opportunity, where first 2 years of life, 85% of the brain growth will occur. So we all give this importance to the first 1,000 days. But this next 7,000 days of childhood up to adulthood are equally important. And our reanalysis suggests that a large proportion of population is missing out on this opportunity. And it is, again, there's a differential as far as, sex, wealth quintile, and residences are concerned. And this is not particularly limited to India, but whole Southeast Asia has this. And if you look at this conceptual framework, we will see that, there is a lot of importance of food system, health system, education, cultural and gender norms that decides our health and nutrition in our population. So finally, what I feel is that while we are talking about front of pack labeling, there are so many other aspects that we also need to talk about if at all we want to make a comprehensive change. So we have to look at the social, economic, and political context, the policies, the food systems. What is the access to the nutrition, food, and dietary diversity? So fortification is not the only answer. We have to look at the food pricing as well. The taxation differential that can be done on healthy and unhealthy foods. The gender norms and gender roles, which are so deeply entrenched in our society, and the problem of adolescent pregnancy. So while I feel that front of package labeling is important, but it's the whole chain of event that leads to the consumption, right from agriculture, farming to processing, the retailers, the traders, the marketing, the taxation. And we need tailored intervention at all these levels, because when we talk of front of package labeling, we are putting a lot of responsibility on the consumer. And when we address something at the end point, that is not good public health. So all of us who are interested in nutrition, we should be talking about, of course, we should talk about the type of labeling. And again, there's a lot of debate going on. There are problems even with the traffic lighting, it seems. So which ingredient are we going to, which constituent will decide the traffic lights? So that what happens is sometimes the one of the ingredients will be low, and that will decide the traffic light. So it's a very complex thing, and the market is very organized, and we are not. Definitely, we who are trying to advocate for this are not as organized. So let us make it more comprehensive, and we cannot stop discussing about the taxations, differential taxations, and agriculture and farming, processing industry, and not just put the responsibility only on the consumer and say that, okay, their awareness is poor. We have to give enablers to people to decide. And the enablers are accessibility and food pricing. So thanks so much for your patient listening, even at the fag end of the day. Yeah.
Thank you, madam, for your presentation and highlighting the various trade gimmicks by companies. And previous speaker spoke a lot about obesity and overweight, but you very rightly addressed the issues of stunting among the adolescents. And because stunting, as you said, is a robust indicator of long-term nutrition. And you also highlighted issues in measurement of thinness. There are some issues, scales are not adjusted as per the Indian setting. So this also gives one of the operational research areas for the participant to look into this issue. And as per your presentation, NFHS 4 shows increase in stunting from the previous year, but there is overestimation issue that we have to highlight. So now, thank you, madam. Now I move to the next session, that is open discussion and question and answers. So,
No. Okay.
So I think in the chat box there is no question so far, but I have one question for the Pradeep sir. This is my query. So is the FOPL is applicable to the food products sold in organized sector only, or it will be going to applicable for the organized unorganized sector also? As in India, most of the part in especially the rural area, unorganized sector only works in our food and nutrition. So if it is there, I will also want to know that what is your plan of action to target this unorganized sector. Sir, please.
Deliberations are still going on for the unorganized and small sectors. And if a policy is going to come, it is applicable to Pan India for each and every product. We understand the small industry is India needs to be given an opportunity. Might be a time frame can be given to them to adopt it. Currently, the small industry is already putting a small labels inside it. So those labels can be redesigned, ensuring a FOPL is there. So if FOPL is going to come, that eventually is going to be there in 2022, it is going to be applicable to each and everyone.
Thank you, sir. Thank you. I request all participants to fill the posters form, which is shared in a chat box, and give your valuable feedback. And now I request Dr. Rashmi Madam to give vote of thanks.
Good evening, everybody. Thank you all. Thank you all the registered participants and participants online, and also who will be going to see later all this YouTube, for being with us on this important commission of front of package labeling and children's health. In the South, we talk more of children's health because that's a major game what we have to look into, because primordial prevention becomes a major important issue at this point of junction, because most of our adults have passed that and they are into secondary prevention. So thank you all for being part of this. And I honestly would want to thank with the lead project director, Dr. Pradeep Agarwal, who was the main initiative, who started all this, involved all of us, and was being part of it. Thank you, thanks a lot. And of course, Dr. Sudeep Bhattacharya, who was with us and who is being part and backbone of the whole situation of this FOPL for occurring in different parts and of course also in the South. My sincere thanks to my director, now our beloved director, Dr. Vikas Bhatia, who within a word accepted and supported us to carry out this, and he was very much interested that we are working on food, which is also his favorite area to work on, and supported us to come to this webinar. My HOD, Dr. Neeraj Agarwal, no word to say to him, he always gives us a free hand to carry out whatever we want and always instigates a idea of research and webinars and all academic activities within the department. Thanks to Sir for that. My dean, Dr. Rahul Naran, is always in support with us to carry out any function, and we do not even have to go and invite him over a phone call. He comes down and works with us. That's his greatness. Thank you, sir. I would definitely want to thank the NIN, the National Institute of Nutrition, Hyderabad, and madam, when we went and spoke about this, was very much interested and said, this is one area which I'm very much interested and always want to be part of. So, because of madam, we had also the main speaker, Dr. Al Argarappa, who was with us, the public health. We met them and we were talking. We had some few discussions. They were very much interested to join us. That's very important. And thank you, sir. From Clinical Nutrition Division, St. John's, we had Madam Swaminathan, who was suggested by Dr. Anurag Uppad, who made us available with such a resource person who could do the needful in a short time and was available with us for that. Thank you, madam. Dr. Madhavi, my old neighbor and also a long-time friend from Mangalore, was with us, and thanks, madam, for being and helping us out, working out with this. Of course, there's the vote of thanks would not have been complete if not for our IT from AIIMS Bibinagar and the IT division also from AIIMS Rishikesh. AIIMS Rishikesh and AIIMS Bibinagar IT department had worked together to happen whole thing. Dr. Pradeep Agarwal and his team worked along with us from Rishikesh to the success of this webinar. Thank you, both the team. Of course, my colleague and the main Sarati for this function was, this webinar was Dr. Bhushan, Kamble, the assistant professor in AIIMS Bibinagar, who held it high and was always enthusiastic, worked together day and night to happen it. Thank you, Bhushan. And with him was a other coordinator and the senior resident, the youngster in the department, Dr. Guru Mishra, Kumar Guru Mishra. He was with us throughout, and most of the designing part was taken care by Dr. Kumar Guru Mishra. Thank you for being with us. Of course, I thank all my departmental colleagues who were enthusiastically participants of this and also worked at their own level to help us out and let us work in peace so that they took up other responsibilities of the department. Thank you all for working together. All the non-teaching staff and other people who helped in AIIMS Bibinagar and AIIMS Rishikesh were part of it. Thank you one and all, and participants, the most important one, who all were with us and who will be with us. Thank you. Thank you one and all.
Thank you, madam. Thank you for you giving me opportunity and holding on this very nice webinar and informative webinar. So now I request all participants to fill the posters form, give your valuable feedback. We will send your e-certificate on your email. And thank you, and I can conclude end of this session. Thank you.
Thank you all.